So welcome back after the break, and we're going to have our last talk now, and I'd like to introduce, I'm very pleased to introduce Dr. Colin Church, who is a consultant in pulmonary vascular and respiratory medicine, and he works at the Scottish Pulmonary Vascular Unit in Glasgow, which is the national referral centre for Scotland for patients who have a diagnosis of pulmonary hypertension. He's also very much involved in the Glasgow Thrombosis Committee, and he manages patients with venous thrombosis at the Queen Elizabeth University Hospital in Glasgow. He's involved with lots of clinical and basic science research and principal investigator in a number of important clinical trials. So very nice to have Colin on the panel today. He's going to be talking about pulmonary embolism and what should we do after the diagnosis. So over to you, Colin.
Thank you, Julia, for the introduction, and I'll just make sure that you can see my slides. Can you see them okay?
Yes, Colin,
great.
We can see
Thanks
them.
So much. Okay, and well, thank you for the introduction, and thank you for the opportunity to be here and talk about pulmonary embolism, and a big thanks to Thrombosis UK, I think, and Joe in particular, for putting this, the whole Thrombosis week, or a bit longer than a week, together, covering such fantastic topics. So my remit today is to talk about pulmonary embolism and the follow-up. Now, that's a huge topic. I'm not going to be able to cover it all, but I've kind of picked some areas that I think are important to talk about, and if there's time, well, there will be time at the end, we can tease these apart or discuss other things if you wish. So what is pulmonary embolism follow-up? And I think, unfortunately, we don't really have any recognised, hard-written model to follow for that, and often it's set up by people locally who have an interest in pulmonary vascular disease. I think it's clear that ideally it should incorporate both hematology and respiratory, I think, are critical to that follow-up pathway. But it's not just about the clinicians. There's multidisciplinary involvement. I think nursing, pharmacy, I should probably have put physiotherapy in there as well, if we're really wanting to do a bespoke service. And I think these services should all come together to try and look after that patient who's had potentially fatal illness, and this, in most cases, a life-altering experience, and are looking for guidance and follow-up. And one of the big concerns I think I've had with the DOACs, they're fantastic drugs, but the connection that patients used to have with warfarin going up to follow-up for INR checks has been lost a little bit. So that initial period in hospital where they get treatment, they've told they've had pulmonary embolism, and then they're discharged, and with low risk in ambulatory pathways, as we heard with Elaine, those patients get put out quite quickly, and it's important that they don't feel lost, neglected, and that we have an ongoing input for them. And that brings me to the quality statement at the bottom, which is from Robin Conliffe's paper a number of years ago, mainly looking at outpatient pathway, but it's one of the quality points that he or the group noted was that they should be making contact with the patient at 7 days, and that's often to make sure that they're still doing okay, they're familiar with their drug therapies, there might be a drug change in doses, etc. But it also stated that there should be a follow-up after that by someone, a senior clinician that is involved in the PE pathway, and that these patients should be managed in that service. And I think post-COVID, we can look at that in a virtual environment, and certainly now in my PE clinic that I share with two other consultant colleagues, we spend a lot of our time doing virtual appointments, either phone or video link. And I think pulmonary embolism follow-up and that initial approach 3 months down the line after their event lends itself quite well to the virtual forum. So why do we need a follow-up for pulmonary embolism? Well, these are just a few of the number of, I think, important topics that need addressed when you're seeing a patient. A lot of the time, the patient that comes to you will have been diagnosed elsewhere, other wards, other centres. I think it's important to always go back and confirm the diagnosis and look at that presentation and risk stratify that patient at the time. Were they high risk, were they intermediate high risk? Because that sometimes has a big play in the subsequent management and how you're going to follow them up. Always look for provoking risk factors. Again, that plays into the way we're going to risk stratify them for recurrent events, VTE. We heard earlier from Bala about malignancy and cancer-associated thrombosis. You'll see that we're not advocating detailed screening for patients, but always be mindful that the patient, when they come back, may have developed a red flag symptom that will need investigated. A lot of time should be spent, I think, making sure that the patient understands the importance of their drug medication and why they're taking those drugs, and making sure that they're compliant with it. And that's where I think a pharmacy role might play a key part. We spend time going over the disease. Remember, this is a disease that patients might not have heard about, might suddenly spend some time with Dr. Google and realise that they could have died from this. And you need to spend some time educating them about both what they've come through, how it might affect them in the future as well, and their ongoing treatment. And then something that's very close to my heart, excuse the pun, is looking for long-term complications of pulmonary embolic disease. And in its most extreme form, that's a condition called chronic thromboembolic pulmonary hypertension, where the blood pressure within the pulmonary circulation is raised and leads to quite marked functional limitation. So I think one of the first and foremost roles of a pulmonary embolism follow-up clinic is to look at the patients and decide their ongoing management for anticoagulation. And I think that's why I say it should be a multifactorial team, because often these decisions can be nuanced, and I think interacting with haematology colleagues is critical to that. This is data from a large UK registry published a few years ago, and it really, I show it because I'm sure most of us know in the unprovoked VTE events, that's where we don't see any clear risk factor for the patient to have this. The taking off a patient off anticoagulation leads to an increased risk of recurrent VTE. That can be as high as 10% 12 months after stopping anticoagulation, and can increase out to almost 30% at 5 to 10 years. But the other important thing I think from this data is that the group that's classed as the provoked included sort of minor provoking factors that or maybe now we would class as minor provoking factors, such as medical illness, pregnancy, peripartum, it's medical admission to hospital for a few days. And if you put them all together, that also included the trauma patients that had their hips fixed and major surgical operations. Their recurrent risk was still elevated beyond what we would class as a normal background risk with time. And it was Trevor Baglin from Cambridge that I think really first showed this when looking at his data, that clearly if you had a major surgical event that led to your VTE, stopping anticoagulation after 3 months did seem to bring your risk back to a standard background risk. But if you had a non-surgical provoking factor, that seem to put you into this intermediate risk of recurrent VTE as opposed to the unprovoked group. So that has led to us starting to get better granularity and understanding, I think, of the what these minor provoking or risk factors might be. And this is data from Prinz et al. That taking from mainly the Einstein studies, looking at the risk of recurrent VT in those patients that had various risk factors labelled as minor transient or minor persistent. And you can see a list of them there. The minor transient included immobilization, maybe long haul flights, pregnancy, lower limb trauma with transient impairment of ability, not being laid up, fixed in a bed for 6 weeks. And then there's the minor persistent risk factors, and that's quite interesting to look at. Obesity might fall into that, comorbid disease such as congestive heart failure, and inflammatory conditions, in particular inflammatory bowel disease, rheumatoid arthritis, those sorts of conditions. And if you look into that, the risk lies somewhere between about 6 and 8% of further VT events at 12 months if you stopped anticoagulation. So these minor provoking factors, I think, need to be taken into account when you're seeing the patient. And that's, again, better done in a more formal environment in a post-PE clinic. And it's led the European Society of Cardiology to, we saw this, a similar slide from Elaine's presentation, to produce these risk factors in a green, amber and red traffic light system to really let us see that if you've got these risk factors, it probably needs an individualized approach. Again, Julia said that's the theme of the morning, individualized approach, and I think it is. Each patient might have their own beliefs in whether they want to take the risk of long-term anticoagulation or not. And this table, I think, is very helpful in helping to direct the way we should look at these patients. We all accept that for PE, most patients should be treated for at least 3 months. And then if you're going to stop anticoagulation, it's level 1 evidence with the major transient reversible risk factor. The evidence base for the minor transient is less robust in there, again, indicating that nuanced approach. So when you see a patient in clinic, I think it comes down to looking at what possibly was provoking that event, their history, their family history, have they had previous recurrent events, and then weighing it up with their bleeding risk. And talking to the patient, I think, is critical that the patient understands the situation. If there's a minor provoking factor, like they've been to Tenerife and they're just back and they maybe had a diarrheal illness just before they left, what is the long-term risk of them having recurrent VTE versus the bleeding risk of being on an anticoagulation? And there are some bleeding risk scores that have been validated in venous thromboembolism. Has bled, we'll know from our atrial fibrillation strategies, but it has been looked at in VTE as well, and then the VTE bleed score. And these scores can help direct us to whether we think this patient is going to have a high risk of bleeding on anticoagulation. And then the other side of the coin is trying to assess their risk of recurrence, VTE. There are a number of scores that are available. Not all are completely perfect. And I think, again, that's where a discussion with colleagues in the clinic are often important, and with the patient using these scores to try and, I guess, identify the future risk of recurrent VTE. But nothing is perfect, and you always have to counsel the patient that these are done with the best intention, but it's a balanced decision between the clinician and the patient. Okay, so that's one key element, I think, for PE follow-up. The next is this entity of post-PE syndrome. So another important role for us is to make sure that that patient is returned to normal or as close to baseline as we can get. And in around 50%, current evidence would suggest many patients might have limitation. And post-PE syndrome is the term given to patients after 3 months of treatment that they have persistent breathlessness, exercise limitation, their quality of life is impaired despite adequate treatment. And you can see here from this Venn diagram that there's a substantial overlap between patients that may have evidence of residual pulmonary venous obstruction but not have any symptoms, and those that have similar findings but have symptoms. At the purest form of post-PE syndrome, I think we've got this entity of chronic thromboembolic pulmonary hypertension that we'll delve into a little bit more. But there's many other reasons that patients might be limited post-PE. I think always important to look for thromboembolic pulmonary hypertension, but it is quite uncommon, said to be between 2 and 4% of patients following acute pulmonary embolism. So the approach to those patients might be taking a sledgehammer to a nut, really, because we're looking for a small problem down the track for thromboembolic pulmonary hypertension. And in many situations, what we do as our first line of investigation is ask for an echo. Now, in an ideal world, that's fantastic. If you just walk round the corner, please, and you'll get your echo, and then we're done. But that doesn't happen. Post-COVID in our centre, our routine echo waits is up to about 52 weeks. So that's clearly not going to offer you the situational resolution that patient is looking for. And there's been some work that's emerging to say, can we actually avoid going straight for echo and try and rationalize our patient population into those that are maybe more high risk for developing pulmonary hypertension and evidence of thromboembolic disease. And Frederick Klok from Netherlands has done a lot of work in this area. Has validated prediction scores such as this one here, which takes into account various parameters clinically and past medical history that gives you a score for whether it is likely that you have possibility of developing chronic thromboembolic pulmonary hypertension, with a score of over 6 being predictive of possible PH developing. And he's not long ago published the Enscape 2 trial, which took a large population of patients that had this clinical prediction score initially applied to them, which excluded quite a substantial number of patients, and then followed up the patients that actually were deemed to go on and be further evaluated for pulmonary hypertension. So this is out of 424 patients, 81 were sent for echo. Of those 81, they then applied another system of looking at ECG abnormalities and BNPs. So if your BNP and your ECG was normal, then you didn't need any further evaluation, and it's said to be normal. If you had evidence of ECG abnormalities, and it was mainly right bundle branch block or right axis deviation, or a positive NT-proBNP, then you went on to have an echo. And what that then showed is out of those 81 patients, 54 were deemed normal with echo, and they were followed up for 2 years. And out of that population, only 1 patient went on to have developed CTEPH. So a failure rate of 0.29% through this whole algorithm, which I think is quite remarkable and would substantially reduce the burden on our echo service as well. But it's not just thromboembolic disease that we need to be aware of in these patients. When they come back complaining of breathlessness, it might be that they've been deconditioned for the last 3 months. they've put on weight, they're now increasing obesity. They might have already been obese, and it's not taking that much to just make them more aware of their breathlessness. Remember, dyspnea is very subjective. What makes one person breathless, high functioning athlete will certainly make someone like myself breathless, who's far from a high functioning athlete. It might unmask other conditions such as COPD, left ventricular systolic dysfunction, and there is definitely a functional or an anxiety overlay that can be provoked by having this diagnosis. And I'm sure we're all aware of patients that have presented not that long after the initial event with further pleuritic pain or breathlessness that are concerned, despite adequate anticoagulation, that they're having further clots. And teasing these patients out can be quite tricky. And we're lucky to have a very good cardiopulmonary exercise test service. And we really rely upon that because it can really hone down on whether you have ventilatory problems, whether you have cardiovascular problems, whether you have muscle problems, whether it's deconditioning. And it's a very good service to tease out. Now, not everyone can manage the bite test, but if you can, it's certainly a very well worthwhile test. I just put this in as well to remind Rachel Hunter's done a lot of work in psychology down in Swansea, looking at this sort of anxiety-induced syndrome that follows on from pulmonary embolism. And that is definitely an entity. I see it quite often. She's called it postthrombotic panic, that you become into a circular, a vicious cycle, really, of physical sensations, and every twinge becomes a pulmonary embolism once you've had this significant disease. So let me spend the next few slides looking at chronic thromboembolic disease, or chronic thromboembolic pulmonary disease, or chronic thromboembolic pulmonary hypertension. You can see that we can't make up our mind exactly what to call these entities, and there's a spectrum of disease that you can get following on from acute pulmonary embolism. Now, luckily, it's just before lunchtime, so these fresh clots that you get from an embolectomy, for example, in an acute event, hopefully won't put you off your bangers and mash for lunch. They're fibrin-rich, they're platelet-rich, they're nice red in colour. Now, contrast that with this fibrotic appearance and relatively vascular appearance that you'll get from the chronic thromboembolic clots that form in 2 to 4% after that acute event. And under the microscope, this is a fibroproliferative disorder that seems to mimic other forms of pulmonary arterial hypertension, certainly in the pulmonary microvasculature, and in the macrovasculature, the big pulmonary arteries can substantially limit flow as well. And you can see that the luminal area here is dramatically reduced by this extracellular matrix deposition and fibrosis. And how do you go about investigating these patients? Well, like acute pulmonary embolism, I think CTPA is probably still our workhorse for this. And actually, I don't know if you can see my cursor on this, but on the panel on the left, there is a laminated, well demarcated eccentric clot in the right main pulmonary artery. Contrast that with the one on my right, which is a large saddle pulmonary embolism, where you have usually the central filling defect, which is more representative of acute disease. However, further imaging is often invaluable when you compare the index scans, such as perhaps in this case here on the left, and then you follow the patient up 3 months later or 4 months later, and you find that that clot is still present in that area. That's definitely a substantial clot burden and would be expected to be having an effect on the patient's symptoms. And then you can look for more subtle signs of chronic thromboembolic pulmonary hypertension, such as bronchial artery hypertrophy. Usually these lovely snaking vessels from the systemic circulation can't really be seen. They're less than 2 millimeters in size, and if you start seeing them here, that's often alarm bells that the pressure is raised, and these are collateral supplies. And that might make you go on to do conventional pulmonary angiography, where you see beautiful stenotic dilatations, webs, cut-offs, and narrowing of the blood vessels as well. And these are essential modalities that we have available to try and look for this pulmonary hypertension and thromboembolic disease in these patients. Why? Because although it's a rare disease, we can actually do something about it and make a difference. These are the terminology that we often use. You might see letters back if you refer us patients, web disease, web slits, occluded vasculature, cutoffs. These are what we're looking for when we're examining the CT pulmonary angiogram. That's just another angiogram showing complete loss of blood vessel supply to the right lower lobe. So you can get quite dramatic effects, and there's clear evidence why the patient would be breathless with this. But we're evolving our ability to analyse patients, and we have access now to detailed cardiac MR analysis and indeed MR pulmonary angiography. Again, this is this is showing that right lower lobe loss of blood supply. Now that's clearly a large vessel disease, but you can actually start to see the blockages at low in the segmental vessels as well. So MR pulmonary angiography, I think, is becoming more and more established as an important follow-up tool, albeit with the caveats of claustrophobia, etc. Now, don't forget about the VQ. We certainly won't let you forget about it, because if you send us a patient, we'll send you a letter back saying, could you get a VQ for us, please? That's not because we can't be bothered doing it. It's just our centre doesn't have immediate VQ access. And while you're waiting for the patient to come and see us, it's often good for them to get this VQ scan. So a VQ scan, I think, across the global community is still regarded as the best test to exclude chronic thromboembolic pulmonary hypertension. Slight caveat that might change, because I think we have certain tools coming for us, but certainly in older, as the scanners improve and the resolution of the scanners improve, I think most of us feel that CTPA is still a very good tool for looking for thromboembolic disease, but the data still supports VQ as having the best sensitivity and specificity for excluding chronic thromboembolic pulmonary hypertension. This is dual perfusion scanning, or iodine subtraction scanning. It's another way of looking at it, which is taking contrast and non-contrast CT scans and looking for areas of abnormal perfusion. And that can be done acutely, but also we're looking at that in the future for follow-up and chronic thromboembolic detection. Artificial intelligence is now getting everywhere, and there are emerging concepts that perhaps on index scans, when the patient first presents with acute pulmonary embolism, we may be able to detect subtle signs of chronic pulmonary hypertension and chronic pulmonary embolism that have been sitting there before, and might allow us to expedite that patient's management. That's still not for prime time, but certainly stuff that might be coming in the future. So once we've made that diagnosis, what do we do? Well, in the UK, you send them to Cambridge, because that's where the main centre for surgical evaluation is. And if they're deemed surgically operable, then they have this condition, this operation called pulmonary thromboendarterectomy. It's a huge operation, median sternotomy, 9 hours on the table, and involves coring out the fibrotic strands that I showed you in one of the earlier slides. That's just the slide to give you an idea of the complexity of this surgery. It's done under deep hypothermic cardiac arrest for 20 to 25 minutes. The surgeon has that long to operate in the right, patient's warmed up, then cool down, and then you do the other side. So it's high intensity surgery. But it's better than medical treatment. So if you can be operated, you have a chance of a cure, and your long-term prognosis is better than pulmonary vasodilator therapy, which is another treatment modality for patients that are perhaps not operable, i.e. the disease is too far out, or they have significant comorbidities that we can't offer them surgical intervention. But the landscape is changing even in that area. Up till about 10 years ago, we would have said that's the only interventional modality we have, but now we have balloon pulmonary angioplasty. And this is like our cardiology colleagues, we're always about 10, no, probably longer than that, maybe 20 years behind. But in principle is the same, where we're trying to stretch these stenotic, fibrotic pulmonary arteries to open up the blood vessels and improve the circulation and reduce the pressure. These are usually done in multiple visits in different segments, and the idea is to reduce the vascular resistance across the circulation. So is there any evidence that actually having PE clinics improves the situation and helps us detect these patients? Well, yes, I think there is emerging evidence that supports this role. This is data from a collection of endarterectomy patients in the top section, showing England mainly here. But you can see a very big hole in Devon, Cornwall area, where there was a very low rate of surgical identified chronic thromboembolic pulmonary hypertension cases back in 2004. And then one of my good colleagues moved to the Bath area, set up a pulmonary embolism follow-up and pulmonary hypertension service. And after that, 10 years later, the incidence or detection rate went up to 8.3 cases per million. So that just surgical cases, that shows you the impact that if you're looking for it and you're following these patients up, you will find it. In Scotland, there is some data supporting that as well. Many years ago, Borders was the main hospital that set up a dedicated PE follow-up clinic. And we did see a spike, as you can see here on the left, of CTEF referrals from there to us as well. So again, if you look for it, you'll find it. And there's some evidence that perhaps if doing that, you're picking them up at an earlier disease. So the pulmonary vascular resistance is the resistance across the pulmonary circulation. As time has gone on, we seem to be picking up these patients at an earlier, a lower pulmonary vascular resistance, which is a lot better for the operation mortality and morbidity. But coming back to that initial presentation of an acute PE, I think we all recognise that the prognosis of those patients is intrinsically linked to the right ventricle. And if you've got a large dilated right ventricle with a low blood pressure, you're a high-risk candidate. Our treatment modality will probably be different from if you have a normal right ventricle and normal blood pressure. But in follow-up, I think it's just as important to try and look at these patients as well and make sure that we're not missing that the right ventricle is still struggling. You'll argue that I'm going back to saying that it is important to try and follow up these patients with echo. That's putting more burden on the service. It is, but there are other modalities that we can use, BNP, that perhaps, but in someone with significant RV burden at the time of diagnosis, I think it's important as a community to make sure that that RV has improved. Final few slides, we should also touch upon travel, lifestyle. Many patients want to know about that after pulmonary embolism, and this comes up in the PE clinic. I point you to this statement that's just come out recently from the British Thoracic Society, pointing in patients that have maybe stopped anticoagulation that it's a bit of an evidence-free zone, like a lot of these things, and it's a discussion with the patient. But certainly most experts, I think, would advocate graduated compression stockings, possibly prophylactic anticoagulation in some form, one or another, for patients if they're going on long haul flights. And the timing that you do after an acute event as well is, again, not clear. It ranges between recommendations from 2 to 6 weeks. I think the longer you can push that out, the better. And if you've had significant clot burden with high risk, I think, again, you should be looking at that right ventricle before thinking about flying. Exercise, if you're a high impact sport, then on anticoagulation, you're going to have a difficult conversation with the patient about probably trying to restrict that. There's good evidence that exercise and returning to exercise improves cardiovascular mortality across the board, but is beneficial in that post-PE syndrome as well. This is a study that was looking at a dedicated home physiotherapy type service where the incremental shuttle walk test improved with that input. And there's other evidence from the pulmonary rehab, for example, 12 weeks impacts and improves your quality of life. I'll finish with these last few slides, patient education, and we often point them in the direction of Thrombosis UK. That's such a marvellous job of having leaflets for patients to learn about. I'm not going to spend too much time because Bala did a great job at talking about cancer and VTE, but just always remember that in closer to 5% of population with unprovoked VTE, cancer might be either present at diagnosis or presenting within the next 4 months, and that's associated with significant mortality and morbidity. But detailed screening is not recommended. Absolutely check for red flag symptoms, weight loss. You do some routine clinical evaluation, urinalysis, and make sure that the patients are enrolled in the age-specific national cancer screening programs as well. Follow-up is essential, therefore, after PE, patient education compliance, determining length of anticoagulation, assessing bleeding risk, look for red flags of cancer and act upon them, and assess for post-PE syndrome, especially looking for that pulmonary hypertension. And with that, I'll stop. Thanks very much.
Thank you very much, Colin. You mentioned at the start, maybe not covering everything, but I think you've had a jolly good try, and that was super. Just to sit back and listen, and some of your imaging was great as well. Now there is a question, and well, it's a comment really, but I've turned it into a question. So the attendee has asked if anyone has a draft business case to support the introduction of a post-PE follow-up clinic. The benefits from what you've told us in the talk are clear for patients, but not sure how to translate that into a financial benefit for the organisation. So that's a really good point. So of everything you've discussed, what is translatable into basically it makes sense to have this for long-term financial goal? I mean, the whole thing seems to me sensible because you're preventing further morbidity from recurrent pulmonary thromboembolic disease. But what are your thoughts about it? Are there some easy, quick, sort of low-lying fruit that you could show your service manager, look, we need to set this up?
So no is the answer, in my opinion. So this is one of those clinics that is very difficult to show financial benefit. Now, saying that, you can quite quickly with the virtual platform say that you could maybe increase your throughput of patients, but they will say, well, we never had that workload before, because you're now creating a workload where you're specifically saying that all these patients should come to you. So that's creating a waiting list that never existed before. So that doesn't go down well with your service management. The other issue is that it's very difficult to quantify long-term complications of pulmonary embolism. So recurrent VTE, chronic thromboembolic pulmonary hypertension. To put financial numbers on that, I think is tricky. You could make an argument that the patients, and I see this, you'll see this, Julia, as well, patients come through that are left on anticoagulation much longer than they should be. And you'll also see the other scenario where you have patients that have been told to stop at 3 months, 6 months, where they should remain on anticoagulation. But I haven't worked out a system how to put a number on that to make that financially sellable to the the service managers. So that's for the clinic. The only input might be if we take it back to the acute stage, and that's a whole different talk, where thrombolytic therapy and catheter-directed therapy may have a financial reduction in length of stay for patients. So that might be the stronger business case, and what you do is you tag on the follow-up onto that going forward. But unfortunately, PE follow-up is one of these things that you do because it's best for the patient rather than it's going to save the trust money.
Well, it's certainly a better patient journey, and I think it's the same for DVT as well. And the other thing is just, there's an awful lot to cover in that follow-up visit.
Yes.
And I'm lucky that usually I have a thrombosis nurse that can then sort of chip away at certain things. And if we don't have enough time, because we only have a certain amount of time in these clinics, but what you've got to try and convey to the patients, often just the natural history of venous thromboembolism. And it may not have been possible to explain that to the patient when they've had the acute episode. So I find a lot of my times just chatting to them about what happens to that clot.
So I completely agree. So the number of times that a patient will say to me, "How do you know these clots have gone away? Why are you not sending me for another scan?" And you have to go through that. I think I tried to make that point in my talk that, when we had INR checks, these patients were coming up to the anticoagulation service, monthly, more frequently that, maybe in certain occasions, and they were having close medical contact, and they would glean information at those visits. Now, especially in ambulatory pathways, the patient barely stays in hospital and is being still treated as, sometimes significant pulmonary embolism, but we're not having that same of medical or nursing or pharmacy input into that diagnosis. And I think the follow-up clinics should be trying to deal with that and educate the patient.
And I think Elaine was touching on where that should be. I think it can be in primary care or secondary care. You need the sort of right setup and the right people in the multidisciplinary team to be there.
Or both. I think, GPs should, primary care, I think, is an ideal situation for, initial touching base with them between maybe that baseline and 3 to 6 months when the patient comes back to a secondary care service. But I guess secondary care has a certain, have different skills to offer in terms of, availability for investigation and recognition of other complications, for example.
Yeah, James has just James Tiernan's just posted a comment to say about the business plan side of things, possibly framing it as an enhancing person-centered experience with some qualitative data may also help move the dial, was James's comment, which is certainly very helpful.
Yeah.
There's another question now, and when post a significant PE, do you repeat echo? Does timing matter?
So, yeah, great question. Availability is one problem with echo, as I hinted. If you've had high risk, so I'm talking, or intermediate high risk, so those patients that present with RV, dilatation, strain, BNP up, biomarkers up, those are the patients that I'm suggesting that we should be making sure the right ventricle has recovered. Now, ideally, that should be done after 3 months of anticoagulation, because by that time the right ventricle should have remodeled. I think most of us will accept that the bulk of pulmonary vascular resolution will have occurred by that time. And certainly, if you're looking for thromboembolic pulmonary hypertension, our surgical colleagues would not be looking to do any surgical intervention until these patients have had at least 3 months of good anticoagulation. Now, that's not to say that, and we've had this before, where patients are deteriorating after 6 weeks, for example, that you wouldn't preemptively do an echo at that point and intervene earlier. But the standard therapy time is around 3 months.
Okay. So I think if there's no more questions, I think that's our talks are over. I want to thank Colin very much for that talk. And I also want to thank the rest of the panel this morning. That's Victoria and Elaine, Anne Armstrong, Bala, and yourself, Colin. And I also want to thank Jerome for just setting up the Thrombosis Week and also inviting us to develop a Scottish theme for this morning. So thank you, Joe, as well.